an ultimate global podcast. Hello, and welcome to our special weekly podcast on trending international and social affairs. You're listening to Saurabh Kora and George Mavros from Sydney.
So, welcome to another exciting episode of Ultimate Global Podcast. And I'm very excited for this particular episode because after a long time, I am having my co host along with us. And I'm always so excited to organize any episode along with my business mentor who has been a major, who has played a major role in my life in the last 2 years. So grateful to have you, George, along with us. He's the CEO of HC Consulting and also a co-host with me at UGP.
Thank you very much. Always a delight to have a chat with you, my friend.
Thank you so much, George. And we also have got a guest from Pakistan. His name is Faizan Ahmed. He's currently the Chief Innovation Officer at Social Medicine Initiative in Pakistan, which strives to humanize healthcare globally by considering the health outcomes in relation to the social, economic, and political factors. So, welcome to this episode, Faizan, and we are very excited to listen to some of your insights that you are having from your experience in healthcare.
Thank you for inviting me, Saurabh. Hello, George. I hope you're well.
Good afternoon to you.
Yep. So the topic for this podcast is towards the finding out the differences between healthcare systems in the developed and developing countries. And I think this kind of lies at the core foundation of Ultimate Global Podcast because 1 year back, when George and I decided to start with a podcast, our main focus was to discuss on these pressing issues such as healthcare, such as what's happening in Afghanistan, such as what's happening in technology. We have had a lot of discussion on technology, business, international education. I think this is one of the rare episodes where we are also touch basing upon healthcare as an important issue. And we all know we have recently suffered a pandemic which lasted for more than 2 years and is still having its after effects in different countries, both in developed and developing nations. And we have had experiences both in the developed countries, even the best of the best healthcare systems have kind of suffered during this pandemic, be it Europe, be it America, be it Australia, or you talk about any developed countries. So, starting off with this key question, I'll point out to Faizan as to how do you see the differences between the healthcare system in the developed countries and developing countries? And before that, would you like to also give a brief context of your business that you are doing in Pakistan?
Of course. So, with regards to Social Medicine Initiative, um, thank you for your question. We actually, like you said, look into the social determinants of healthcare outcomes. So, whether it's ideology, systemic violence, all of these systemic factors, how they come into play when it comes to looking into a population's healthcare outcomes, right? And so the concomitant conclusion from that and logical conclusion is that you need to make it population centric. So that's been our essential effort. We've directed that effort towards Pakistan. We started off with that, but we also have done projects in USA. And there was an Afghan community which migrated to Pakistan, with whom we also strive to help them in terms of humanizing their healthcare. So, with regards to that, I would like to come to the question. I think there are stark differences between the healthcare systems when it comes to developed and developing countries, and COVID was the great equalizer in that way. I mean, if you have a lot of services and a lot of facilities available in the developed countries, right? You have them in Canada and US. You saw them break down and dilapidate. You saw the whole system come down in a way, and in fact, it's just uncanny how Pakistan was at the forefront of being able to deliver, of being able to keep COVID cases at a minimum, right? And we had neighboring India as well, in which the cases were skyrocketing. So it's been, which I think we're still trying to figure out what's been happening, right? We were able to come up with a vaccine real quick, and we were able to distribute it. albeit a little inequitably, right? You have a lot of vaccines in the developed countries, but with the developing countries, we're still looking into vaccinating the populations. So I think that COVID was an equalizer in the sense that whether there was a resource limited area or whether there were more resources in area, that wasn't a big factor in terms of how the population uh, suffered from COVID. So apart from that, generally yes, you have a difference of higher resource and lower resource settings, and with those and all those attached problems which come with it. If you have a very highly formed system, if something like COVID comes unprecedentedly, what happens is that the whole bureaucracy, the whole system is like, okay, we've been doing this for so long, and now we have to really adapt and pivot. So how do we do that, considering we have so many protocols? I think that was the challenge of the West, and for the developing countries, uh, it was again a bit of more like come as you go, right? Because there are a lot of protocols which need to be systemized, which need to be finalized over here, in terms of emergency response, in terms of sick care, and then there's also a general inability to pay for these services. Right now, this is also an important point to talk about. I mean, is it only the fact that healthcare is more expensive in developing countries, and with developed countries that isn't the case? Do people have higher socioeconomic levels which then help them out? That's not necessarily the case. I mean, the US is a primary example of how the healthcare system is seriously dilapidated, right? And the inequality is just so stark and blatant. So I would not want to just focus on the fact that just because there are higher resources in a particular place, that means that the healthcare over there is perfect, right? It is actually a lot of stakeholders come together, and what emerges is a healthcare model. You can't necessarily just have a template, go into a particular population, and just think that the template will work out exactly how you intend it to. So these are just some of the factors which I wanted to talk about. I would love to hear from you, Saurabh or George, how the pandemic was in developed countries, in Australia, for example, and how you guys managed to go through it.
According to the statistics I'm looking at, the United States had 1.02 million deaths,
Okay,
with
deaths.
with a population of 330 million, and Pakistan has had 30,400 deaths. So with a population of 180 million.
Okay, yes. One of the reasons for that, I really believe, is that we are a very young population, right? So a lot of COVID, which we had, a lot of us were able to break through that, and it's one of the youngest populations on earth. So I think that age factor also comes into play over here. I mean, you can look at Italy and how Italy was completely ruined by COVID in that sense, right? And one of the biggest reasons was that it wasn't about, yes, young people were getting COVID, but it was also the demographic of old people within that particular population, and so that also really uh, sh- tilted the results towards one side, and it's quite an inexplicable phenomena. I still am trying to understand this thing. That is, it could be that we were young and everything, but honestly, there could be different strains. Even though the reporting was coming out to be very homogenous, like yes, you have a Delta variant over there, so it's spread across the world as well. But that is exactly what social medicine initiative is about. What cultural factors over here inhibit or amplify the spread of coronavirus, right? That is a very important thing to look into. So maybe it's the age demographic, but it's also maybe our lifestyle as well. So I will share my experience later on. I would just like to hear more questions from you regarding this, on what we did and how we ended up with lower cases than we expected.
Yeah, I would just want to bring in.
I would think that a lot of people would see India and Pakistan as similar sort of countries. Now, whether that's
Exactly.
true or not, I don't know. But in India, they had 43 million cases with 525,000 deaths. So that is quite a that is a very stark difference between two countries. And you raise an interesting point about the average age demographics of the population, things like that. Because yes, I certainly agree. Many commentators have said that Italy suffered so badly because they're a much older population. But yeah, one of the interesting things for me with COVID is the fact that it didn't seem to stay true in any statistic. If you looked at its behaviour and you took countries to compare one against the other, it didn't. There wasn't any. I don't believe that they've been able to come up with a finite per head of population that's accurate.
Yeah,
I
I
completely
just want
agree
to
with
bring
that.
in. Yeah, I just want to bring in a political angle here to this discussion as well. When we are talking about these figures, there was a lot of underreporting that was coming from developing countries, including the South Asian countries and most of the developing countries. We know that. So, for example, I think the deaths that you pointed out in India were reported to be around 400,000 deaths. But if you look at the unofficial figures coming from the other sources, such as the WHO, who pointed out later that the actual death figure can be 10 times the deaths reported by the government. So there seems to be a political angle into it where the governments are trying to hide the actual number of cases and the actual number of deaths to make sure that everything is hunky dory in their countries and they are doing better than developed countries. But it might not be the case because there is a lot of underreporting here in this case. So I would actually want to know from Faizan in this regard uh, as to what you have to say in terms of the underreporting and all these factors playing a major role, because underreporting at the end of the day doesn't improve the situation that you have in your country. And it is just a political game played by the parties to gain more votes and not work on healthcare as their priority, right?
Definitely, this sort of political angle is very relevant. Uh, I think the opposite case for of this political coin would be the true as well. That besides underreporting, there has probably been overreporting as well, right? And a lot of cases where you had deaths, there have been reports about how unnecessarily they probably died from a different cause, but they were noted to have died because of COVID. So uh, let's like complicate the situation a little further. The PCR test even in itself isn't 100% accurate if you think about it. So those sort of complications have also arisen. So people have ended up doing multiple COVID tests. Sometimes there have been alternatives such as antibodies tests, right? So um, again, this is something that I would definitely like to help you out with, but in terms of knowing the truth about this, I'm still trying to understand. And it's still an enigma for me how Pakistan, considering its socio-economic status, could have braved through this. But being over here, I did see that there was one really important factor for the rural sector or for people with who were lower in the socio-economic criteria, right? Which was that they were really scared of not being able to attend someone's funeral because of if someone did get COVID. That was a huge, what should I say? It was just a huge determinant, right? In terms of people acting in accordance to what was happening. So whether it's underreporting, overreporting, uh, Pakistan also faced an issue of not have of a dearth of ventilators. All of these things we were experiencing as well, right? Um, but I did see things like because of when everything was shutting down because of COVID, the people did help each other out in terms of like providing food to them because everything was closing down and everything. So we're a philanthropic nation like that, right? And I don't know. I honestly don't know whether they're overreported or underreported, but I completely agree with their point that there is always a political angle to it, right? There's a reason that Bill Gates has written a book on pandemics and is thinking of having a global task force for this, right? So to be prepared for the next pandemic. And he had a video which said 5 years ago that we might get a pandemic. So I mean, we're still probably trying to understand what's happening over here, right? I mean, the those who were prepared best to handle this sort of pandemic ended up facing the brunt of it, right? And those who weren't strangely slithered out of it, and we are really looking into what the actual situation is. But COVID has had a different response. I will say that on different nations because of their socioeconomic determinants, and that has a big impact on healthcare outcomes. So the healthcare system in Pakistan is relatively cheaper as compared to many other countries, right? And we do have a good amount of population turning out to be doctors over here. The issue is actually when it comes to providing an environment for patients and doctors to thrive. In this particular case, what mostly happens is that the best of our doctors actually go to Australia or America and go and learn these things, right? And not only go in terms of excelling their skills, but end up staying over there just because of the uh, viability of it, right, so to speak, in perhaps every dimension. So here's another important fact. I mean, but I don't want to make this a gender segregated thing, but even in terms the culture that we have in Pakistan now, it's recently changing. But for the longest time, healthcare and became was something of a nurturing perspective over here, and so a lot of women ended up becoming doctors. Right? What happened was that our culture was as such that once they got married, or they do get married in certain social classes, they have to give up their practice, and so a lot of while the best of our doctors are going out and going to other countries and offering the services, a lot of female doctors over here end up getting married, and so they're unable to provide that sort of consistent service over there. So, with that context, when we come towards healthcare itself, like hospitals, uh, in the urban centers, the main urban centers, you do see good quality healthcare, which is affordable by the middle class, upper middle class, and the elite class. But when it comes to the lower middle class or people situated on the peri-urban settings or people in rural areas, that is where the problem starts to arise. That is where we cannot say that we can definitely say that healthcare needs to be more inclusive, right? Recently, what has happened is that we have started private. So the government always struggles with somehow providing us with these facilities, right? So there has been a lot of private initiative recently in these rural areas. And one of the rural areas that I have worked in, I have within those 3 years, we went into that population. We went on the side of emergency preparedness, right? So just helping take the patient in the in patient to the hospital, right, and providing quality care in between. That was essentially what I had been doing. So that was something that when we went into that population, we trained locals over there, and within 3 years, this rural and while training this population, our good luck was as such that two private hospitals popped up over there, right? So before that, we had to go around 50 minutes away to the nearest urban hospital, which had a lot of risks attached to it, as you know, because the average response time needs to not go extend beyond 15-20 minutes, right? And so we started off in that scenario. It was very hard actually to convince the locals about consent, about the fact that they had to, if they were choosing a public hospital that was 50 minutes away as opposed to a private hospital which was 25 minutes away, then they had to be informed about consent and that they were consenting towards these things, and we were not legally liable if something happened because we had advised them to go to a private hospital. But again, our advice doesn't give in the money that they need to actually afford the healthcare over there. So that was essentially our struggle in terms of emergency preparedness over there. So the point I was trying to make is that yes, now there's been a recent shift towards having welfare hospitals or private hospitals in rural areas. As I said, Pakistan is quite inclined towards philanthropy. But again, philanthropy is only half of the solution, right? Because then you need to have a system, you need to have certain protocols, you need to have precedents which help you to come up with contextual protocols, essentially. Uh, So that's what we've been handling, and that's what I've been looking into across Pakistan as well. That increasingly this private partnership is increasing, and there has been this recent um talk of integrating health tech as well, right? And considering that to be a solution for problems of inclusivity, right? Especially for marginalized groups or underprivileged groups, and that has a set of problems attached to itself, which I would love to talk about later on. But I hope I've been able to give you a brief overview of what the healthcare system is like. It's cheaper. People over here still, there are a lot of gray areas which we need to figure out still in terms of how to manage healthcare, whether it's at this in the sick area or whether it's bringing the patient to the hospital, right? So just these protocols really need to be refined still.
So within within Australia, generally speaking, people would consider that healthcare is accessible. When you get to the country areas, though, they for they may be able to have doctors and all that sort of thing, but getting to hospital for operations and that, then they have to travel a fair distance. So throughout Pakistan, is is there some sort of medical assistance reasonably available to the population, or is that only in the cities, and once you get to the country area that dissipates? Or
I think that your speculation is spot on. It does dissipate like any other isolated area. Again, the point is that we're a developing country, so that would mean that our infrastructure is the primary cause which we need to really invest in. Uh, we have no proper roads in those rural areas, right? And what happens is that if there's an emergency, so the emergency medical personnel that we've trained, they travel to a certain point beyond which they have to walk with the stretcher. It takes another additional 20-25 minutes to get over there and then come back, right? So it's not just the road infrastructure, transport infrastructure, but the telecom infrastructure as well, which needs to be really looked into. I mean, the fact that this is perhaps one of the biggest problems. If I were to advise someone whether we need to invest in transport or whether telecom, it's definitely telecom, because what happens is that there is no access at all. Then if there is no telecom, and what happens, that becomes an opportunity for charlatans and quack doctors, local charlatans and quack doctors, to jump up to the opportunity and pump their patients with steroids, giving them chronic illnesses and diseases, right? So that this is not only in the rural area, but it also happens in the peri-urban area, right outside the outskirts of the city as well. So I don't think that this is a local phenomenon. Honestly, this could be probably happening anywhere, and that is why we need good quality business to actually expand and be able to provide such services, so that which is credible and which is life affirming in that sense, right? I mean, if those spaces are left in those rural populations for people to occupy, and what happens is is horrendous. It's horrible. I mean, the sort of stories you get to hear over there, it's you wouldn't believe that this is happening like half an hour or an hour away from the city, but it is. And I personally am in the capital of Pakistan, Islamabad. So this is where, like, I've been operating in a rural area 50 minutes away from the capital, and there is no ambulance service as such. We have ambulance services that have been sponsored by various philanthropists, and what happens with that is that that's all with good intentions, but what happens at the end is that you just have an ambulance driver. There is no trained person at the back taking care of the patient, right? It's a very sad fact that even in urban areas, even in our Islamabad urban areas, our public hospital has ambulances in front of it, which do not have such personnel behind them. And since they're not over there, the probability of death or having a chronic illness increases exponentially. So you only see these ambulances going and picking up dead bodies. That's it. That's their purpose. That because they cannot provide that service, so that ambulance is just a transport vehicle for the dead, for corpses. And it's morbid. It's just we've it's just one if one person was behind them, a lot of things could change. right? And that brings my point to me to the second point, that there is a lot of discrimination in terms of when you go to these rural areas, it becomes really hard to administer medical care if you have an opposite gender sitting in front of. I mean, it's mainly if a woman is sitting in front of you, right? So you have a conservative setting where if a trained male person goes, the family isn't comfortable with them treating the female. And so what we did was that when we went into this community around 3 4 years ago, we saw that this was a problem, and we trained female emergency medical personnel from over there as well. So we were able, in a conservative rural setting, we were able to establish the first co-working space along with its necessary problems in that particular area. So we did face a lot of backlash, but we recently been getting a lot of recognition from media outlets for this work. Imagine that this is a conservative rural setting. These women are not allowed to, for the longest time, have not been allowed to go out of their houses without male companions, and suddenly they have to wake up in the middle of the night. And this is the beauty of doing this healthcare in that particular of doing healthcare in that particular setting, is that they have such big hearts. It doesn't matter that whether it's their official timing or not, whether whenever you call them they will be available, because that is the need of healthcare over there. There is no other way of going about it. So I don't. If people talk about being politicians, and them investing into various things, but I think if you want to be a politician in that particular area, the most apolitical way of becoming a politician is to become a healthcare provider. Within 3 years, these people have become heroes within their vicinity, right? Women, girls, for the first time, can look up to women doing anything other than staying in the kitchen or rearing kids, right? And and the best part is that that it's a need, right? It's not that we just want to cash in on the women empowerment narrative or something like that. There is a genuine need for this. And when other women look, and when the other girls look at these women and see how they're saving lives, it just really inspires them and inspires us as well, honestly, because this was really hard to establish. We had to really convince a lot of stakeholders at the start that, hey, if you don't do this, this is really going to go, and this is just going to go bad, right? So with 3 years we did this, and then the coronavirus came. When the coronavirus came, George and Saurabh, can you imagine that for a terrorist religion like Islam, right? That's what the general media talks about, right? You have, in a rural setting, uh, the Maulvis are announcing to the general population, right, the religious leaders, that they don't come for prayers right now. All right, we have these recordings with us over here in a local conservative setting. This wasn't even happening in Islamabad, and over there they were saying that don't come for prayer. All right now, stay in your houses. We don't know what's happening. This was in the first wave of the coronavirus, and people listened not because, and this is just, I'm still trying to understand this phenomena. I mean, we can obviously understand that there is an elevated atmosphere of superstition within rural areas, right? But when it came to scientifically appreciate this pandemic, the rural folks turned out to be much more appreciative and much more open and receptive and progressive as compared to the urban areas, right? We were still trying to figure out what to do over there. And I think this is the exact sort of phenomena we can look into when we're talking about COVID, and how it impacted developed countries more as compared to Pakistan, which is a developing country, right? Having a fully formed system does not necessarily mean you're going to perform really well in an unexpected scenario like a pandemic, right? It is actually about, can people come together, right? You saw how many people over there were against vaccinations in America, in Australia, in Canada, right? There was no, what do you call it? Nobody came out on the streets to fight for their rights in terms of wearing or not wearing masks over here. It was a collective panic, so to speak. Everyone was like, okay, let's just quickly try to follow one thing, right? We don't have an authoritarian model like China, although we would love to, but we don't. And I think that is very interesting how these sort of events played and turned out. being I think what I'm trying to say is being too underprepared or overprepared, being on